Welcome to the 2016 Cystic Fibrosis Education Day. This is our third annual Education Day. And thank you, everybody, for coming. And I hope we got a chance to mingle out in the foyer there and get settled in. A little housekeeping. We have these new plastic and metal and glass portable computers. Some of you may have one of these. Please put it in a state where no one else will hear it in the event that it buzzes or rings. Turn it off, mute it. You know the drill. Pretend like you're at a movie and mute that thing so that we don't disturb one another or the speakers. Secondly, the restrooms, if you don't already know where they are, if you go out either one of the exit doors here and to the right, the ladies' restroom is on the right, and if you keep going toward the end of the hall on the right is the men's restroom. In the event that you have any questions throughout the event, our different team members in the UT Health Northeast orange shirts are here to answer your questions and are here to help. So are we ready to get started? All right. I'd like to introduce our keynote speaker. Dr. Fernando Torres is a professor of medicine at the University of Texas Southwestern Medical Center. He's also the head of lung transplant and pulmonary hypertension programs at William Clements Jr. University Hospital in Dallas. His clinical interests include pulmonary hypertension, lung transplantation, lung volume reduction surgery for emphysema, viral infections in immunosuppressed patients, and clinical outcomes research in lung transplantation and pulmonary hypertension. That's quite a sentence there, Dr. Torres. He has served as principal investigator or co-investigator in many clinical trials. Dr. Torres earned his medical degree at Cornell University Medical College in New York. He completed his internship and residency at the University of Texas Southwestern Medical Center and a fellowship in pulmonary disease, critical care medicine, lung transplantation, and lung volume reduction at the University of Colorado Health Sciences Center at Denver. I tell you, us sciences centers have awful long names, don't we? Dr. Torres is board certified in pulmonary disease and critical care medicine. Please welcome Dr. Fernando Torres.
Thank you. Thank you, Steve. Thank you all for inviting me to talk about lung transplantation, specifically in cystic fibrosis patients. I remember doing my training in Denver, I enjoy advanced lung diseases, pulmonary hypertension, tertiary lung disease, cystic fibrosis. And when I finished my fellowship, I did lung transplantation because I saw it was kind of a way of giving new life to someone. A person who could not walk or breathe, and suddenly they had a new wind as soon as you put those new lungs in there. And it was the satisfaction of surgeons that they go in, do a surgery, and boom, the patient is doing great. But as a medical doctor, you never get to do that. So it was kind of neat to be able to do that. So when I graduated from fellowship, I came to UT Southwestern, and then I was seeing a lot of the cystic fibrosis patients as me in the CF Foundation program that we have, and I was helping the CF team, and also doing lung transplantation, and then over time, I moved towards just lung transplantation. But it has been a journey where we have made a lot of accomplishments, and I wanted to share some of those with you. So, you want me to use this microphone? Lung transplantation is a fairly new field. We're talking about 50 years, give or take. Back in 1960s, when the first lung transplant was done, it was a disaster. We did not have immunosuppressive medications available that would keep the patient from rejecting the organ. So the patient only lived for about a week. Not until 1980, when suddenly cyclosporine becomes available, that then suddenly We have a new medication that allows the patients to be on lower dosages of prednisone, and thus the outcomes start improving. It's not until 1982 when the first heart-lung transplant was done in Stanford. Then in 83, lung transplant by itself. Then sequential lung transplant, doing one and then putting the other one right away in 1990. In 1991, that's when UT Southwestern opened its program for lung transplantation. The other big hallmark or big event in lung transplantation was in 2005. Up until then, patients were placed in the waiting list very early, even if they did not need a transplant, because they were accumulating time. The longer you were in the waiting list, the higher your position in the waiting list. In 2005, we changed that. We said, there are patients who are so sick when we meet them, and they're in the waiting list and they're dying 1 month after being placed in the waiting list because they are very low in the wait list. So we decided to change the wait list to how sick you are. The sicker you are, the higher you are in that waiting list. And that changed a fair amount on how patients get transplanted and the successes that we are having. So when we look over the past 50 years, we're doing about 3,000 transplants a year nationwide, and some international centers are included in this graph. One thing that we are noticing is that centers are more comfortable now doing double lung transplants rather than single lung transplants, meaning putting 2 lungs rather than 1 lung. And that's good because now we are able to get more organs from a donor. But it's bad because there are certain patients who only need double lungs. They cannot have a single lung. And now those organs are being shifted toward those patients. Our survival is improving. Back in the 1980s, early 90s, the survival was the light blue curve. Then over the past 15, 20 years, the survival has shifted towards the green light. So that's successful. That's better. Our patients are doing better despite us changing how we allocate organs to our patients. The other thing that we have seen is a shift on the transplant single versus double on the emphysema patients, as well as the interstitial lung disease patients, where now we're doing more double lung transplants on that population. For cystic fibrosis patients, we always have to do double lung transplants. Why? Because if you only do a single lung transplant and you leave the other native lung behind, there's a lot of pus in that lung. That pus will move towards the new lung, and the patient would die from recurrent pneumonias. So we have to take both lungs out. The neat thing about cystic fibrosis is that our patients they have the best survival after lung transplantation. If you look at the green curve, that's cystic fibrosis. We're talking about a 10-year survival close to 50%, which is much better than any other type of advanced lung disease. So that's why centers, we like to do a lung transplant on cystic fibrosis patients. They're young, they're fun, and they live longer. But obviously, if we can avoid doing a lung transplant, absolutely. And that's why centers exist, so that we improve the life expectancy of that native lung, so that you are in a better shape going to a lung transplant and you can have a better survival. Let's skip. Obviously, there are a few things that do not allow us to have a great survival. One of them is being on dialysis. That's why if one of our cystic fibrosis patients has significant renal disease, we will do a combined lung kidney transplant. If they have liver disease, we would do lung liver transplant. But dialysis, diabetes, they are risk factors that affect our 1-year survival in our patients. And we have to accept that perhaps those patients may not have a 50% 10-year survival in maybe 8 years or 7 years. But for sure, it will be better than the quality of life that they're having before transplant. One of the reasons that cystic fibrosis is so much better is because they're younger. And the recipient age is associated with improved survival after lung transplantation. And that kind of makes sense. For example, I just had a referral yesterday for lung transplantation, a patient who is 80 years of age with bad interstitial lung disease. I look at the patient, I'm like, you don't look 80, but I'm pretty sure after I do surgery, you are going to look 80. And the kidneys are going to look 80 years of age, and the liver, etc. So, a lot of times we use physiological age for lung transplantation, but there will be a point where you're just taking too much risk. And obviously, we said we should not proceed with transplant. Over the years, you have noticed that a few centers have evolved into doing many transplants a year. And what we are noticing is that the survival on those centers seem to be better than in transplant centers that do not do as many transplants. And initially, I was a little bit hesitant to believe that, but now that we are one of those centers, it makes sense. You walk into a unit, everybody knows about lung transplantation. The nurses, the dietitians, the social worker, the person who cleans the floor, the patient who brings the food to the patient in that room. They all understand, I have to wear a mask, I have to wear gloves, if I am sick, I'm going to tell my supervisor, today I cannot work in that floor because I can give this infection to one of the patients. The whole institution works in sync, and that makes a big difference and affects survival. And that's what we have noticed is centers that do more than 35 transplants a year, they tend to have better survivals than otherwise. At one point, we were doing heart-lung transplants, especially for cystic fibrosis patients. We would do a heart-lung block and take the heart and give it to another person. But that has fallen out of favor. And currently, in the United States, we don't do more than 40 heart-lung transplant blocks a year. And most of these patients are transplanted because of congenital heart disease, though from time to time, we may have to do a heart-lung block on one of our cystic fibrosis patients. And again, the survival after heart-lung block is not as good as double lung per se, but it's close enough. So if you have to have a heart-lung block, the survival will be similar, and you should not shy away from it. Now, over the past 5 years at UT Southwestern, what we have been doing is increasing the volume of transplants that we do. Currently, about 10% of our patients are cystic fibrosis patients that we do a year. And that's fairly good because that way all the staff knows about lung transplantation and cystic fibrosis patients rather than having an anomaly. Oh, wow, today we just have a CF patient. Most of you are familiar with the chest x-rays of our patients with cystic fibrosis, large lung volumes because air can go in but cannot get out, and multiple cystic lesions, characteristic of our cystic fibrosis patients. When we do lung CT scans, then you can see all these cystic lesions throughout the lung, characteristic of patients with fibrosis. So when is it that your doctor is going to refer you for lung transplantation. There's not a fixed criteria, but there are guidelines. For example, if your forced vital capacity is below 40%, or your FEV1 less than 30%, or you're hypoxic, that's a time for the lung transplant team to start. Because your survival. Why don't we do that?
Get it? You don't.
Okay.
Turn it on.
One, two, three. Whoa. So there is not a set criteria. If you're 45, you have a forced vital capacity of 45, I'm not going to do a transplant. No, what that means is that we're going to look at you for sure if your forced vital capacity meets this criteria. But before that, there are some reasons to do it. For example, we have had patients that we cannot keep them out of the hospital. Month after month after month, the patient has to be hospitalized. They may have hemoptysis, coughing up blood. So there are other reasons that a patient with cystic fibrosis, we may have to do a transplant before their lung functions drop that much. We are always going to do a double lung transplant on our patients with cystic fibrosis. We cannot allow to leave an infection behind and then suddenly immunosuppress you. The infection will take over. On our patients with cystic fibrosis, we do have some concerns. They're young. They have been sick for a long period of time. So they have not had those teenager years. Suddenly we do a lung transplant and they want to have those teenager years, and they can do silly things that we all did as teenagers. So a lot of times we have to have that heart-to-heart conversation that, smoking is not something good for the new lungs, or drinking, etc. They start partying. They have not had a chance to go and have big parties like we did in college, etc. So socially, there's a lot of support that we have to give our patients. Also, they are exposed to antibiotics for all these years. Now that our patients are living to age 42, 45, for many years, they are being exposed to antibiotics month after month. So the organisms are more resistant to antibiotics. And obviously, we are all familiar with Cepacia, Cepacia, where it's just we don't have antibiotics to kill that bug. So if we do a lung transplant, the likelihood of being a successful lung transplant is poor. There are other organisms like Mycobacterium abscessus, where we're in defense. From time to time, we say, we should take that risk, and we have taken that risk with some of those organisms. And case by case, we may consider and doing a transplant with Mycobacterium abscessus. They tend to develop diabetes, and diabetes is a problem because it lowers your immune system and how you fight infection and rejections. But all and behold, absolutely, when a patient with cystic fibrosis needs a transplant because they are at that stage where they are not able to walk from here to the door, gasping for lack of air, or they are having so many admissions, they don't have a quality of life, they're living in a hospital. Absolutely. A lung transplant can give them a completely different lifestyle. They can now walk, go to college, go and work, spend time with their siblings, be a child, be an adult, whatever stage they need to be. So I wanted to spend a little bit of time now talking about what's changing in lung transplantation, what's new that it's able to help our patients and our programs. The first thing is we all have bad memories of patients who we got attached to. I remember um, one of my cystic fibrosis patients, she was 14 years of age, and her brother have had a lung transplant. He was 16, and I've been taking care of the older brother as well as her for many, many years. And she got sick. She got to the point where I could not keep her alive even on a breathing machine. So suddenly, we said, we have this technology called ECMO, extracorporeal mechanical oxygenation. And this is how it looked. You had the patient in between all those machines. There's a patient in there, and we put her in that machine, and after 72 hours, we got an offer for a transplant for her, but she was brain dead. We tried to wake her up. She would not wake up. We did a CAT scan of the head, and she was dead. But this technology was available. It just was not utilized because of the number of complications that we were having using this technology. All and behold, about 5 years ago, the technology changed. All that equipment is simplified in that little box. So now suddenly those cannulas can be placed on the patient's neck. The machine is connected to the cannula, and the patient can be oxygenated, and you can remove the CO2 of the patient directly. What that allows us to do is that patients now can walk in the unit, stay stronger, and we are able to keep the patients alive. So far, our record is 45 days until we get a lung transplant for them. So one of the things that we have been able to do at UT Southwestern is increase the survival of our patients while we are waiting for that lung transplant, because something catastrophic happened that we were not able to perceive, or a bad pneumonia happened, a bad pneumothorax, hemoptysis, etc. And we are able now to keep the patient alive while we search for an organ. So that's looking at keeping our patients alive while we're searching for organs. But another thought that we had was, one of the reasons that we are not doing more transplants is because we do not have enough organs available. So what if we were able to find a technology that would allow us to increase the number of organs that we use? So there are two technologies out there still in research. The first one is the TransMedics, and the second one, the ex vivo. And this is the TransMedics. What this technology allows you to do is that currently all the transplant centers have a radius of about 3 hours flying time. More than that, we get very scared of going, harvesting an organ and bringing it back, because the time where that organ is outside the body is so long that then we believe that the lung is not as good as if that time was very short. So for example, if I'm in Dallas, there's an organ offer in Alaska, I probably would say no, it's just too far. This technology, though, it allows us to do is we take the machine to Alaska, put the organ in the machine, and then we bring the machine with the organ to Dallas and then use the organ. So it allows you to go farther out to harvest organs that in the past we couldn't. We decided, though, that there was another technology called the ex vivo. This technology, what it allows you to do is you take the organ, you put it in the machine, and it allows you to see how the organ is working. So many times we get a call from the UNOS organization that there's a potential donor and that your patient is the first one in the waiting list. Do you want this organ? You look at the organ in the computer, all the information, and you say, wow, yes, this organ looks good. Or you look at the information and you say, golly, it doesn't look great, but I have this gut feeling this organ would work. It's just I cannot take the risk of taking an organ that I don't know that is going to work because the outcome is death to my patient. So a lot of times we discard organs that our gut feeling is that they work, but it's just we are not 100% sure, so we have to turn them down. Imagine now taking that organ, you put it into this machine, you test the organ for 4 or 6 hours, check their compliance, how the lung is expanding and deflating. You can test the oxygenation. You can test the pressures in the blood vessels of the lung. And then you say, yeah, it's going to work, or no, this is not going to work. And then you use the organ. By doing that, we are expecting to increase our organs by about 10 to 15%. And this is what it looks like. It's kind of science fiction. You have the organ in that little cupule, and you can do bronchoscopies, you can check the airway, you can measure the pressures in the blood vessels of the lungs, you can check the oxygenation in it, etc. So we acquired that technology about 2 years ago, and we had been working on trial and error. Let's first see if we understand how to use the technology. So we had lots of experiments over a year. We did easily 5, 6 tests to make sure that all the team knew how to use the machine. And we obviously had a core number of nurses, doctors who learned how to use the machine. Sometimes it was frustrated. What's happening here? Sometimes we had fun. We went to restaurants, etc. But over time, what we have been able to do with these technologies is increase the number of patients that we have been able to help. This is patients that were dying. We put them on that ECMO machine, and then we did transplant. So on those 3 years, we saved about 7 patients. So over the past few years, what we have been able to do is make sure that patients can get into our clinics within 2 weeks. We did the 500th lung transplant this year. We have been able to be rewarded by UNOS for many of our achievements. But the reason we do this is because of patients like Mr. Gideon in Fort Worth, an architect, Mr. Michael Jones. He's 20 years after lung transplantation. Whitney, you remember that little machine? She was the first person that we used this machine on. She's a patient with cystic fibrosis who basically was sick. The day she was in the hospital when they asked us to see her, the moment I saw her, her lung collapsed. And we were able to put a chest tube, but she was so sick that we could not ventilate her, and she was the first one that we put her on ECMO. She walked the unit on ECMO, and then about 2 weeks later, we were able to find an organ for her, and she is now about 2 or 3 years out after lung transplantation, 3 years. Sanders, cystic fibrosis kid who he told me, you know, the only reason I want this transplant is because I want to walk on graduation day and get my diploma. had the transplant in April, and then in June, he walked the aisle and got his diploma. And we were talking about that ex vivo machine. Mr. Herstig was the first one in Texas to get that an organ that was harvested that way a few months ago, and he's doing very well. But again, we went to look at an organ. We were not sure if the organ was going to work. We took it, brought it to UT Southwestern, put it into the ex vivo machine, then tested it. We felt that it was going to work, and then we used it on the patient. Otherwise, we would have said, no, we cannot use these organs. So all of this has been done by expanding outreach throughout North Texas. Like at UT Tyler, we have a we help the UT Tyler pulmonary team with any referrals for transplant, etc. But we have El Paso, Amarillo, Lubbock, Midland, etc. You remember that we were talking about it's important to have the whole institution in sync. The more transplants you do, the more in sync your institution is. So over the past 5 years, we have been increasing the number of transplants that we have done. So currently, we do about 60 a year. We have done 53 so far this year. So we'll end up somewhere in the 80. And that puts us about number 8 in the nation doing lung transplants. So over the past few decades, there have been multiple advances to the medical care of our patients. We have been able to improve their survival. We have been able to increase the number of donors that we can have, and we have been able to increase the survival of our patients in the waiting list. The new allocation score has helped us move the patients who are very sick all the way to the top of the waiting list so that they can have a chance to have a lung transplantation. And remember, it's important to have an institution where you do a transplant where everybody understands lung transplant, and it's not a rare event. It's a day-to-day kind of activity. Thank you. Oh, a few more, they'll kill me. These are, lung transplantation is not just Dr. Torres. Golly, no whatsoever. It's a whole team of people. You have medical team, we're 6 of us. Surgical team, we're 5 of us. Administrators who support this program. These are only a few people. Nurse practitioners, nurse coordinators, social workers, dietitians, speech pathologists, ancillary personnel that are there to help our patients. Intake coordinators, outreach coordinators, etc. For sure, lung transplantation is a multidisciplinary team approach to care of patients. It cannot just be a great lung team, it has to be a great lung team, a great GI team, a great kidney team, a great cardiology team, etc. You are as strong as your weakest link in this graph, and that's we all understand it, and that's why everybody has to be the best that you can. And this is my family. I'll answer any questions. Thank you.
Wow. In my attempts to keep the focus on cystic fibrosis, I didn't introduce myself earlier. My name is Stephen Day, and I work here at UT Health Northeast, and I'm actually the manager of web operations. I don't work in patient care areas. I don't have a medical background, and so I've been spending some time today really learning about CF and the disease and who it affects, and I don't know about you, but I am just completely overwhelmed at the technology that's being utilized, and Dr. Torres, what you're doing, and the lives that are being saved. And I think about just a few years ago. Look at how things have changed just in the last 5 years or 10 years or 25 years. And this is truly a miraculous age that we live in, that this technology exists. We have some time here. Does anyone have any questions right now for Dr. Torres? If you do, I'm going to carry the mic to you, so please wait and I'll bring the mic. We are going to do questions and answers at the end of the entire event as well. But any questions right now?
Francis is never shy. You know, each center is going to be a little bit different. At UT Southwestern, we have used an age of 14 and a weight of 90 pounds. And the reason for that is because our technology, bronchoscopes, etc., are a certain size. We don't have tiny little kids technology. So we have to put a limit somewhere. Having said that, there is a new ruling coming from UNOS over the next 1 or 2 years that has been approved, where if you are a pediatric patient, age 18 or less, you have to be done in a pediatric hospital. So that's coming out there. Fair or not fair, you like it or no, you don't like it, that's good. That's what's happening. But for now, we're able to do transplants up to beyond 14 years of age and weighing more than 90 pounds. Yes. So the question is, you know, we did not talk too much about complications after lung transplantation. So we have some time. So what should we expect? So we get the patient in the waiting list. We meet the patient. We spend 1 or 2 weeks doing a workup for transplant. We present you to the transplant committee. We say, yeah, we can help this patient with cystic fibrosis, and we say we approve for transplant, and financially, socially, everybody clears the patient, so the patient is active in the waiting list. There we get what we call a lung allocation score, LAS score, that goes from 0, you don't need a transplant, to 100, where you're very, very, very sick. Most of the time we end up somewhere between 30 and 50. 30 being COPD patients, 50 being the ILD patients, cystic fibrosis somewhere in between. The time to wait for a transplant, our wait time, 50% of our patients are transplanted within 3 months. Now, that doesn't mean that you are going to wait 3 months. You can wait 5, 6, but it's not like 2, 3 years like it used to be. Kelly, how long did you wait? 6 months. And that's more common for our patients with CF. Their score is a little bit lower than the ILD patients, so they tend to wait a little bit longer. But that day, we, the doctors, get a phone call that there's a potential donor for your patient. We look in the computer for the CAT scans, the blood gases, testing, HIV, hepatitis, all kind of tests. And at the end, we say, yeah, it looks good. And that's when we call the patient into the hospital. And the patient has 3 hours to get to UT Southwestern. That means we can have airplanes arranged. You can be in El Paso. You live in El Paso, we give you a call, and we have a little airplane that brings you over, etc. But you need to be able to make it to UT Southwestern in 3 hours, because when you come to the hospital, we're going to do a bunch of tests. So I need about 1 hour to run all those tests, and we need to go and harvest the organ and bringing it. But so far, we do not know for sure that the transplant is going to happen. We think the organs are good. Then we send the surgeons. They go look at the organ, and by then, the patient is already in the operating room. By the time they look at the organ and they say, yes, it looks good, then they start the surgery. From that point on, there's no backing off. Meaning, if the airplane trash is coming back, patients already had, the chest is open, etc. So from that point on, it's a full go. We bring the organ, and by the time the organ gets to the hospital, all the chest has been exposed, and all the blood vessels, airway is already ready to be cut to hook up the new organ. It's scary. Every single patient that comes out of the operating room into the intensive care unit will come with the endotracheal tube, with a breathing machine breathing for them, a catheter in the neck, measuring the pressures in the heart, a catheter in the arm, measuring the pressures, the systemic pressure, a catheter in the urine, draining the urine, 2 chest tubes on each side at least. And it's scary. If you have not been, if you have never seen a patient like that, if you're a relative, etc., it's very scary. The one thing to remember is that every single patient comes out of the operating room like that, and they do pretty well. So we expect our patients to be in the intensive care unit. Over the next day, we take the tubes out, and over the next 3 to 5 days, they're in the intensive care unit. As soon as we extubate them, they're walking in that unit. They hate me for that, but yes. But they're walking in the unit, and then we move them to the floor, and then we start teaching. They have to get accustomed to all these medications. The taste buds get messed up. Food doesn't taste the same, etc. Sometimes they are not able to swallow well, so they need a dop of tube and be fed by dop of tube until they are able to swallow correctly, etc. But by day 10 to 14, all the tubes are out, the chest tubes have been taken out, and we have been able to teach them all the medications, how to take them, their names, what color, what pill is, etc. They don't ask me because I tell them I have no idea. But it's a lot of education. They have to learn how to breathe and what's normal and what's abnormal. It's not normal anymore that if I'm walking from here to the door, I'm short of breath. That's not normal. We give them speedometers to take home so that they can monitor their lung functions. And if the lung functions drop by more than 10%, they know the telephone number to call, and 24/7 we are here to take care of them, etc. So a lot of education, but the expectations are that by 2 weeks, they're home in Dallas. And then they stay in Dallas for the first 2 to 3 months, and then they can move to their hometown. Rejections, infections, absolutely. Every single one of our patients are going to require medications to keep that organ viable. All of them are going to receive 3 different types of immunosuppressive agents. All of them may have side effects: prednisone, blood sugars, Imuran, liver function test, Prodraf, kidney damage. So that's why at the beginning we see the patients twice a week, then once every week, then once a month. And for the first year, we're following the patients very closely because there are so many things that can interact with our medications and cause damage to an organ, that the earlier we are aware of the damage, the quicker we can change them. We expect every single one of our patients to have 1 episode of rejection in the first 3 months, 80% of them, 70 to 80. That doesn't mean that you lost the organ. That means that your immune system recognized that organ doesn't belong there and is trying to get rid of it. And we have to increase your immunosuppression, change your immunosuppression. But for the most part, the sooner we identify that problem, the easier it is to have a good outcome. Over the past 10 years, new technology has been developed. For example, now there's a technology called Silex. What that allows us to do is a simple blood test, but it tells us the activity of the T cells. It measures the ATP production of a T cell. Well, that's awesome, because if that T cell is very active, that means that they're responding to something. They're not happy and they're having to interact. So you know that a high number means my immunosuppression is, the patient is not well immunosuppressed. And the other way too, if the number is very low, I have them on too much medication. Technology like in the immunology lab, HLA lab, where now we can find antibodies that are made against the HLA of our donor. So we monitor those tests and see if a person's levels are going up. We may have to intervene. We may have to get rid of all these T cells, B cells, and change your immunosuppression so that you don't produce all these antibodies. So over the past 5-10 years, the field has changed significantly. That's for sure. It makes my life a heck of a lot more complex than before. But our patients are the ones that are doing better, and it's very, very rewarding in that sense. Yes. I have no idea. I don't want to know. No. And that's really a question. One thing is the cost. The other one is out-of-pocket cost, which both are important. You as a patient, you feel the out-of-pocket cost. We as society feel the total cost. But it ranges somewhere between 300 and 450 that first year. So it's not cheap for sure. And but we cannot help everybody either. And that's why we have to be very selective, because we do not have enough organs available to help everyone. And I'm not sure we could afford as a society either, but that's a different question. Well, thank you guys. I'll be around a little bit longer after everything, and I'm pretty sure we are all happy to listen to Kelly soon.